Okay. So this chapter is fundamentals of health behavior change. And a preface to this chapter is that this was something that I felt like really intrigued by because a lot of what at least some of the early criticisms of lifestyle medicine was that patients don't really want to do it anyways. And maybe people are not thinking about lifestyle medicine that way anymore. Um, but or not as much anymore, but I was actually really intrigued by this because maybe I only saw this selection of patients that I saw in the emergency department who really felt like disengaged with their health. And I was just like, this will never work in my head. So I really did want to get through this chapter and understand what they were saying. And when I actually practiced in the emergency department, before I opened up my own clinic. Oh,
Why?
oh yeah. So when I actually practiced, I was actually nervous to start talking to people about their lifestyles, and I thought they'd like throw me out of the room or just like really be angry with me, but they were so receptive, and it really encouraged me to just keep kind of like using the stuff that I've learned in this course. So we're gonna start with the objectives again. So fundamentals of health behavior change is about 10% of your test, and these are the objectives. So the first one, summarize health behavior change theories such as the health belief model, the social learning theory, and the trans-theoretical model, and their application to lifestyle medicine practices. So we'll go through those three specifically, and I'll also give you some tidbits here and there. So the health belief model is that it has to do with people's own personal beliefs about their own health, their perceived susceptibility. So like if they believe it's a threat to them, perceived severity, that if they believe that they're going to suffer some major condition from what you're explaining, and then perceived benefit and offered solution. They have to actually believe in the solution that you're offering as well, and the perceived barriers of the solution. So they also have to think that it's not going to be impossible for them to do. And any cues to action, and this could be a trigger event, or it could be like advertising, some kind of like, maybe they sort of like felt like they knew smoking was bad for them their whole lives, and they need a cue to action at some point to turn the corner. And then self-efficacy, which will help people kind of like carry out the practice that you want them to carry out. And we'll talk about what self-efficacy actually is defined as in lifestyle medicine as well. So there's a diagram below, figure 3-1. It talks about some of the factors that modify people's threat perceptions and their likelihood to action, and how that leads to their motivations to actually make the behavior change. And some examples of this are vaccines, early detection, and screenings. So the reason why these examples are important from a test taking perspective is because the questions are going to be phrased like, this person is having such and such thoughts, they're doing such and such things, and they're going to center it around one of these types of examples, like a vaccine or a screening cancer detection. So think of USPSTF, and they're going to center it around like some kind of actual topic. And so it's helpful to understand that which model relates to which actual health topics. So vaccines, for example, if you see vaccines in the question, they're thinking about getting or not, then you should think health belief model. Okay. And there was one question where social ecology was one of the answers. And it sounds like some of the other models of health behavior change, but it's not. So that wasn't the answer, just so you know. Another one is social cognitive theory or social learning theory. That was one of the three things mentioned. And with that one, it has to do with kind of like you are a product of your environment in addition to your own logical thinking powers. and that will determine your behaviors and your personality. And it does kind of like, you know, pull that into it. And I think when the reason why we brought this up is because there were some social, you know, like that's the word social, and they mentioned that in the subjective. So just so you know, that's what this one actually is. There's a social cognitive theory. Um, I forgot to put this in the presentation, but in my book on table 3-3, social cognitive theory is laid out in the same way of the health behavior belief model here. And the main thing to know for social cognitive theory is something like safe sex behavior. So again, like you might be logically aware of the risks, but it's really dependent on your social environment sometimes, what behavior you're going to choose, and that could be really powerful. So from a public health perspective, for example, that would be where you wanted to target your interventions. So it's safe sex behavior is the example there. Yes, so that's what safe sex behavior is. Dr. Whitman. So the next one, the last one, which is the most important one that will carry us through so many of the other objectives in this, is the TTM, or the trans theoretical model of change. So this is kind of how
Sorry, but I mean, like, if you had to put that in a STEM, there was a person is in class learning about safe-sex behavior, or is it a person knows inherently that they should practice safe-sex behavior? Like, how would that be
It's
worded?
like, will the person, which kind of belief model would you sort of target to improve safe sex behavior? Or which kind of like health change belief model, or not belief model, what health change model would you think about if you were trying to target somebody's safe sex behavior? But if you just see the word safe sex behavior in the STEM somewhere, then I would just think of this one. It's kind of like, you know, when you're doing your boards and it's like you see, you know, 35-year-old African American, you know, something mediastinal on the x-ray, you think, you know, sarcoidosis, lupus, whatever, like, you know, one of those things. So it's like that for this, but it's not a big part of the test. So I would just, I don't know, I don't remember the stems for this. Other than what I've already, other than the information I've given. So for trans theoretical model of change, so this is the biggest one. I should have probably put it on its own page, but I think there's more to it on the next page anyways. Yeah, so the idea is that there are these stages. Actually, it's a good view of it. So the first stage is pre-contemplation. And with pre-contemplation, it's like don't they're not asking for any advice. They don't think that there's anything wrong with what they're doing. They're not in a place where you can be like, so which gym are you going to get a membership to, and actually like plan out their actions. This is not like, you know, this is often where we find people who don't think there's anything wrong with their smoking, where they're not in a place where you can talk to them about it. And then the next phase is contemplation. So the contemplation is like, you know what, might, I might be convinced, I might not be, and I'm still thinking about it. There are some factors I'm still considering. It might be too hard, and I'm sort of getting over that hump of the change that I'm thinking about making. Preparation is when they've actually decided. This is like the turning point between contemplation and preparation. They've actually decided that this is what they want to do. And now they have to actually get through doing it. They haven't started, they're preparing to do it. They're learning recipes, they're buying stuff in the grocery stores, they're thinking about their quit dates. They're sort of like, this is like where they're actually planning to do things, but they haven't actually done it. So the day they start to do it is now you're in the action phase. And that has its own struggles. You're doing, this is actually where action planning comes in the most, and you're reassessing things, you're developing a support system, you're learning where your relapse triggers are. There's so many things to this. And then when you've sort of troubleshooted all of that, then you're in the maintenance phase, and that's where you don't have to struggle so much to get yourself to do things, and you just keep going. Once you're in the maintenance phase for at least 6 months, well, I think the timings are here. Where is it? There is a question on the maintenance phase. Yeah, goal reached and remain consistent for greater than 6 months. So once you've been in the action phase for greater than 6 months, then you can count yourself in the maintenance phase. So, I hope that this makes sense. You can relapse to any one of these phases. That's not, you know, it doesn't necessarily just go back to the one before. And anything else? Yeah, smoking cessation is a big one for this one. So if you see that one, then think of the TTM. Really, the TTM is one of the ones that I would just memorize forwards, backwards, everything about it. So again, pre-contemplation and contemplation, we'll get to these questions in a minute. But the patient comments is I don't, or I can't, or I don't need to, or want to change, or I can't change. And the possible response to that, which again, you do have to know for the exam, which is on the exam, is how will you know when it's time to change? And some of the other things that you could do is just talk in general about the health risks associated with some specific behavior, like, for example, the risks of cancers for lung cancer or something like that. The coaching technique that you want to employ. First of all, positive psychology is something we'll talk about in detail and later. So that is one of the things that is mentioned in this chapter, PP, positive psychology, but that applies to all of these, and that's not something, there is a whole chapter on that. So we will talk about that in detail later. It's one of my favorite chapters, but the technique for these first two phases is called motivational interviewing, which again, we'll talk about in this chapter in detail. So I'll get to that in a second, but that is really important because that's often, so what the question will be like is like, there is this patient, they are thinking or not thinking, they'll give some kind of scenario that you have to identify which stage, which readiness level, which TTM they're in, and then what's an appropriate response. And some of them will sound great, like great responses, but you have to understand that they're actually CBT responses. So you do have to know which stage they're in, pre-contemplation or contemplation, and which ones, and how to identify if it's motivational interviewing or not. And so you will have to pick out the motivational interviewing for these two phases. So what contemplation will look like is I've thought about it. Maybe they're thinking about changing within the next 6 months. And that's what that's kind of how you respond is, are you considering a change in the next month? And maybe you can get a little bit more personalized with their health risks. So you have a family history of such and such, or your kidney disease is such and such, and the pros and cons of changing. Okay, now we're in the preparation phase. This is a planning to change within the next month, which I've already talked about. The person is already stating now they've made this transition. I am ready to make a change. And they are actively planning to do so. And, it's not that it will take a month to make the change, but it's like, it's in the immediate future that they could make it next week, they can make it that day. Often my patients leave my office like in pre-contemplation or contemplation, and now they're already in action. So it's not something that has to take a month or anything, but you want to kind of pre-think about some of the relapse triggers and ask who their support systems will be, and troubleshoot some of their thinking with CBT, which we will get into CBT a lot and what those responses will look like. And then the action phase. So change started, they're already starting, it might be inconsistent, they might not have met their actual therapeutic goal that you've prescribed them, but they're working towards it. And so they're in this phase, I am changing. And some of the responses are, what is giving you the most trouble, or how can your support network help you, or how can I help you? And then you can, the discussion can be on modified action plans. So you always want to make your action plan a little bit achievable. So if they're not achieving it, you can modify that. And then review barriers that come up, and talk about their social support systems, what they can add to that, maybe a class here and there, to check out the senior center, whatever it is. And again, CBT for these next two phases maintenance, their goal has been reached. I have changed, you are doing well. What have you overcome and how have you done it? Talk about coping strategies for any kind of stress that they're still feeling, because now they're doing the action, but they might still be a little bit stressed about it. And the CBT involved with that is, there's CBT involved with that. And the termination is they're no longer thinking of it as a change. This is just their lifestyle. So we all come with some good behaviors, some bad behaviors, and we're all a work in progress. And some things we don't even have to talk to the person about. They've already been doing it. I have patients that, they're already teaching me how to make action plans using Dr. Michael Greger's, daily dozen on ChatGPT. Weekly food, plans and stuff like that. So they've done the work before they even come to you. So but you could get them there as well. And that's the termination. And this isn't really on the test, but just explain. Okay, so how do you come up with these numbers? This number right here, the confidence level. So the two questions are, on a scale of 0 to 10, how confident are you that you will master these areas in the next 3 to 6 months? So these numbers are very important, these 3 to 6 months, these 0 to 10 for the exam. And then same question for confidence, but instead use important. So there's two things. So this is one of the objectives, demonstrate readiness, importance, and confidence skills. So how confident are you in the next 3 to 6 months? And how important is it to you that you'll master these in the next 3 to 6 months? And then that is what determines their readiness, which, let me see if I have this in my book. There is, I think in the foundations book, there is more to like how those two numbers come together. But really the question I remember the testing on is this 3 to 6 months part and what the numbers actually mean part. So I think that's why I didn't focus on that, but it's just this 3 to 6 months. That can be a variation if somebody's like 1 to 3 months or 6 to 12 months. That's not the answer. It's 3 to 6 months. And then what the questions actually mean. So 0 to 3, if you determine it's 0 to 3, then it's pre-contemplation. If it's 4 to 6, it's contemplation. If it's 7, it's preparation. And then again, if it's anything above 7, 8 to 9 is action and 10 is maintenance. So you just have to know that correlation. So, and it's actually the readiness skill. There are more, before we move on to therapeutic alliances, I just want to mention again, there are more models of health behavior change that weren't in that objective. Previous objective for this was that you have to identify at least 3, be able to understand at least 3 of them, but they would test on 3 other ones. So I guess they gave you the 3 ones that they're going to test you on already. So if you are interested in other models of change, I think they are interesting. I think this was like one of the more interesting chapters. Like I said, some of them are, overlapping, but some of them are, there's like the self-determination theory about taking multivitamins, and that is about like, and healthy eating. And there's the precaution adoption model for radon testing, the diffusion of innovation theory, which is like new forms of birth control and technology. So anything new, there has to be like a process of diffusion of innovation that people are on different levels of for how quickly they'll adopt. Like, or you have your early adopters, your innovators, your early adopters, your early majority, your late majority, and your laggards. And then you have the organization development theory. So you have, that's the theory for just improving clinical efficiency and flow. The other thing to know about this is like, some of these sound similar to a health behavior model, like the social ecology theory. And we put those in here because, so you could just get familiar with the terms and know what is and what isn't. In the answer choices and the multiple choice, they'll put things in that you'll be like, oh, I've never heard of that or whatever, maybe I should have learned that. So we put those in here so that you'll know what those are and you'll know if those are or aren't. So organization development theory is not the same as organizational behavior theory, which is totally different. So we put both of those in here so that you can understand those. And then there's an ecological systems theory. And also there are the social determinants of health, which I don't think they don't test you specifically on them, but I think it's a good thing to know. So we do have that in a nice little table for you.
Excuse me. Can I ask a question?
Sure.
when you were saying, what's the question instead of confidence, use
I think it's
importance? What were you
readiness.
saying?
I think it's readiness level.
No, but what's the actual question that you were saying? I
Oh,
missed.
the two questions that you'll get tested on are this aspect of it. So, um, is it the 3 to 6
Oh,
months?
how confident. And then, okay, I got it. Sorry.
Yeah, the timing of the questions that you'll ask,
Okay.
or like which phase their score is in. Like you've determined that this person is a confidence or a readiness level of 5. So which phase are they in? And you might be tempted to be preparation, but it's actually contemplative. So um, that might be the other question. Okay, so then the next objective, apply the process of building effective and therapeutic alliances with patients that foster their personal growth. So therapeutic alliances comes up throughout this chapter, and it has to do with like the Sigmund Freud determination of like what you and your patient have an alliance on. Basically, it's their health goals. I mean, it's like you can't determine their health goals, they have to determine that, and then you have this therapeutic alliance of how you are going to get there together, and it fosters their personal growth. So how do you make the patient feel that you are aligned with them and that you're not basically talking to them as if you know better for them than what they might think? And this is tough for people who we were all trained in sort of like a paternalistic healthcare system. So some of the tips that they've included, which I will explain, is use inclusive language like we or us, um, and use people first language. So person with diabetes instead of a diabetic. Ask permission around sensitive subjects. So is it okay if I weigh you? Um, can we talk about your alcohol? Is it okay if we talk about your alcohol a little right now? Alcohol use. And then acknowledge any previous efforts in a positive way. So every single effort anybody has ever made is worth acknowledging in a positive way. Inspire awareness. So this is a little bit like the reflective reframing kind of things, but sometimes people come in with their blinders on, and you just kind of want to open up what it could be. And the treatments are kind of like to offer an intervention, make sure it's matched intervention to their readiness levels, empower the patient by encouraging their own ideas, discussing their support network. And then, so the first environment is just like creating a positive environment. This next one is like what you can actually do. And then create an action plan and then collaborate with qualified health and wellness coaches. So creating this allied group of people that are telling the patient the same thing. You don't want people telling them different things than you are. And then their follow-up, you want to reiterate that your role in motivating them and review, update diagnoses, utilize positive psychology, and we'll talk about that again at a later time. If goals are unmet, make revisions based on their confidence levels. So again, every single goal that you want them to do, you want them to feel like they were successful. And then create a new action plan if you need to in the follow-up, and then review progress made um, and future directions that they might want to head in. So this is a constant thing in my clinic. We're constantly revising and recreating and redoing, sometimes backtracking on their goal, sometimes forward tracking on their goal. Like it wasn't as hard as I thought, that kind of thing. The next thing is, sometimes clarifying the goal. Sometimes people they replace one vice with another, and it's, something that you didn't know was something. Anyway, so patient tools for self-management. So some of the tools that you can employ for developing this therapeutic alliance are CBT, social support community, employment programs, community support, community programs, digital technologies. There's so many things out there now. Like some of my patients are just in love with these apps that you can prescribe. Behavior contracts, these are evidence-based. Evidence is inconclusive sometimes, but they are aids. They're not really contracts, but sometimes it really does help with accountability. And then this mantra, I always say skill power over willpower in my practice. So you want to make sure that somebody feels like they can do the skill that you're actually. So I have like a cooking class and it's basically centered around just making people comfortable using their Instant Pots because they're so uncomfortable. And it's like something I didn't realize. And they're not willing to admit it, but they're afraid. And so just, I grew up around a pressure cooker like my whole life, like, and I've actually seen things explode. So it's like, oh, the Instant Pot is so nice. But for other people, it's like they're not comfortable. So skill power over willpower is a huge thing. So this is a lot of content and it covers a lot of the different, objectives. So I might say like we've covered it in the future objectives. So explain how to collaborate with your patient to promote health behavior change. So there is a step by step in creating this action plan. And they talk about some of it here. There's like, use SMART goals and do whatever. So we just put all of it in to one table. So the steps are explain your role as a provider. So say that, you are a consultant, the expert in the physiology, anatomy, the evidence in health, and you want to work with them to achieve their health goals. So you explain your role like that. And then you share their diagnosis. You have been diagnosed with such and such hypertension, whatever it is. And that will lead you to this possible bad outcome. And I'm trying to prevent you from, that's the goal that you want to prevent, and then describe evidence-based lifestyle medicine prescriptions. So incorporate some kind of like, this is an example, something very evidence-based that this is the evidence for you have to do like 150 minutes per week of a moderate exercise. That's like their therapeutic goal. But they're not going to start there, right? You want to do like an action plan according to what's achievable for them, but you have to give them where they're headed in the long term, because you don't want to say, oh, just start with 15 minutes and never tell them they have to get to 150. You have to tell them where they need to be for the therapeutic prescription that was, evidence-based. And then you want to recognize any of their progress that they've been making and use positive psychology to affirm and encourage. Again, we'll talk about that later. And then determine area for change. So maybe we can make it a brisk walk now, and maybe you could do it 3 to 4 days a week. And assess patients' confidence and importance levels. So again, like, is that possible? How confident do you feel? How important is it to you right now? One really good example of the importance thing is like, I tell my students, my patients who are students, like, this is not something I need you to worry about. I'm telling you, this is like a goal that I want you to have for a future, but right now you're as a student, it's going to be not, this is a temporary thing in your life. If somebody's preparing for a wedding or something like that, like I don't, like I do try to couch the importance of the recommendation in the next 3 to 6 months of their lives. So, and then if the score is greater than 7, then you want to have them elaborate on their goal and actually make a plan for how they're going to achieve it. And that action plan is something that's very specific. It's very measurable, it's very attainable, and it's very relevant and time bound. These are all going to be on your test. Like each one of these things, they're going to vary the question in different ways about like, was it time bound or not, which is a big one. Like, so for 30 minutes, twice a week, like those kinds of time things. Is it relevant to their actual goal? Is it a measurable thing that they can actually measure? Was it achievable or attainable? And then again, very, very specific. So where are you going to walk? How are you going to walk? What park? Are you going to be on treadmill or not? What was the speed? Like everything has to be specific. They love the the more specific, the better. Okay, steps in creating the lifestyle action plan. So then you can go further. You can ask the patient about anything they need. How can I support you? Create strategies to overcome any obstacles. Like if it's raining, what will you do? Connect patients with support systems, family members. There's actually going to be one of these things that's going to be talking about support systems. Confirm patient's commitment. So you can, again, evidence is inconclusive about getting a contract signed. Implement accountability. So how can you actually track it? So the tracking piece is there too. Like what are you going to use to track what you're doing? And then a schedule the follow-up, which is in 1 month typically. Apply motivational interviewing, cognitive behavior, health coaching, and positive psychology techniques. Again, we are going to be talking about motivational interviewing and cognitive behavior at length right now. We've already talked a lot about health coaching, like the coaching table. And then the positive psychology, we're going to do in a later chapter. I think I've said that like 10 times now. So motivational interviewing, there are some mnemonics here. And the whole idea is that you want to try to not encourage an actual specific goal, but rather kind of like encourage them to want to achieve any goal. So you want to remain as non-judgmental as possible. You want to listen, encourage the patient to share by using open-ended questions, which is in the core skills. And then you want to let the patient redirect to any area that they might want to talk about. You want to have a lot of empathy and understanding for the patient's feelings. Sometimes, you know, that can be by restating their feelings and telling them that you do understand, or sometimes it could be by sharing from your own personal experience, which is encouraged in lifestyle medicine. Contrast between the present and what their health goals are, if they have any. Everyone has some kind of health goals, but if somebody is trying to protect their kidneys from dialysis, but they are saying that they are, there was nothing wrong with something else that, or, they're telling you about their present. It's like, you kind of want to make sure that they can see the contrast between where the patient is right now and where they want to be, and say, like, this is where, and allow the patient to form their own conclusions about it. So don't kind of like give them the punchline. You want to kind of like tell them, try to help them get there themselves. And then support self-efficacy. So self-efficacy is going to come up in one of the next slides. So I'll talk about that. The core skills are open-ended questions, affirmations. The reflections is tested. So there are different kinds of reflections. These are the different kinds. And they give you, we've given you examples of each one, and what you could say. And then they will do this on the test, and then they will ask you which one it is. And they're confusing. So I would spend some time on this chapter, on this table. Summarize is, you could say, okay, now we've talked about this, and now we're going to kind of like, this is what we've decided. Because these discussions, once you get into motivational interviewing, can go on forever. I'm just saying. And then the 5 R's are make sure that if there's some kind of relevance to the patient, so your tangents aren't too long, and that, and make sure that you've talked about the risks, maybe in general terms if they're in pre-contemplation phase, maybe in more specific terms if they're in the contemplation phase, to the patient's health of some kind of behavior. The rewards of the behavior change, any roadblocks that are either perceived or real, and then repetition. So repetition really helps in this, motivational interviewing. They're constantly just like kind of repeating, building empathy, building, kind of supporting their own confidence, open-ended questions as much as possible. And then these reflections are part of motivational interviewing. So that's a nice thing too about reflections, is that you automatically know that they're in motivational interviewing. So one of the examples that I remember being on the test, double-sided, I know I need to exercise more, but I just don't have time. And this is the important part here, is this and. So when you see the and, you have to kind of like think about this one too. You are aware that exercising would be a benefit to you, and you realize that your schedule is busy. So it's like a double-sided reflection. And then I mean, I don't know why they name things like the way they do, but basically it's like show 2 simultaneous perspectives at the same time. So it's different than the amplified. So amplified is, I'm here because my husband says I drink too much, and you can amplify it by, like, what you're hearing is your alcohol use is completely healthy and you have absolutely no concerns about it, because they're trying to say something like, my husband thinks, like, instead of they think. So you can amplify that and just like kind of like, say, is this what you're saying? Like, I'm just amplifying your statement. So all of these are sort of like that. And I don't know, I mean, timing being what it is, I would love for you to go through this, and if you have any questions, I'd love to, I like these, but like, it was this chore to memorize. like which ones were which. So that I'll leave to you to do. And if you have any questions, please bring it forward. So now cognitive behavioral therapy. So this is kind of like something that you, before you even walk into the room, you're thinking about your own internal dialogue, any biases you might have, identify which cognitive distortions are present in your own self. You can write factual statements to replace your own distortions, and then you could practice all of that. This is like, I don't expect, like, that's not on the test, but anyways. So recognizing non-productive thinking, there are cognitive distortions that are listed here, which I did, it's a 2-page table. I did memorize these. I don't remember being tested on that, but I guess it might be. It's an easy thing to be tested on. And they were kind of fun to learn. CBT was always something I was curious about, so it was kind of fun to be able to learn it in this. Explore, so assist the patient to become more aware of his or her thoughts, emotions, and resulting behaviors. And you can use the reflection skills that we've talked about to explore that. And then reframe, help the patient see the situation differently, substitute a more realistic interpretation, foster a new self-talk. So this is like you are actually challenging what they're saying instead of just reframing it, which we just talked about in motivational interviewing, these reflections. You are actually kind of like, I mean, not reframing, instead of just reflecting what the patient is saying, you are reframing it. So you are challenging, exposing maybe some underlying beliefs that they have kind of interfere with like their actual behaviors. So the ABCDs are like, let's just identify what actually happened, the action. What do you think about it? Like, I had a heart attack. What do you think about that? What beliefs do you have about what happened? What caused it? They might be on a completely different page than you. What are some consequences? How does that make you feel of those beliefs, and how do they make you feel? And then how can you dispute what's another way to think about it? Could it also be this other thing? And could that challenge some of the beliefs that you have? And then what's the effect? How do you feel now? So you always want to go back to like managing the patient's emotions. That's a huge part of changing behavior. And it's literally built into CBT. So you can't make any progress with the patient if you don't understand how they're feeling. You might not need to explicitly ask, but you do need to identify how they're feeling and respond accordingly, because if they're feeling defensive or if they're feeling inquisitive or whatever it is, then you have to be able to identify that. Some people are better at hiding that than others. So 10 common cognitive distortions and reframed thoughts. So again, reframing, not just reflecting. You have an all or nothing thinking, overgeneralization, mental filter, and we've all seen all these: mind reading, fortune telling, magnification, minimization, and then personalization, blame, emotional reasoning, mislabeling, and disqualifying the positive. And we put a ton of examples in here. If you have any questions, please let us know. Okay, the next one is summarize the evidence to support the use of behavior change techniques in clinical practice. This is, not necessarily tested. I wouldn't focus too much on this. Use the skills to open inquiry, reflections, and empathy to develop and maintain a therapeutic alliance. So we did all of that in the therapeutic alliance slide. Open-ended questions, empathy, we talked about all that. Describe the impact of positive emotions on success of health behavior. So we will talk about this in depth later. But some of the benefits about this with positive psychology, that it improves attention, open-mindedness, creativity, troubleshooting, creativity, problem solving, and ability to reach a strategic perspective. It builds resilience. Positive psychology is basically about finding the joy in what in your own value systems and how those relate to what you want to achieve with your health goals. So you could see how it could be just all around beneficial. Positive psychology is throughout your entire appointment from beginning to end. So develop patient-centered written action plans. We did that with that steps, the stage match responses. We gave you all those responses, examples. And then summarize the process of follow-up for ongoing lifestyle change progress. So we did a little bit of the follow-up already. So how the follow-up looks, how might you want to rechange your, so this is one of the reasons why we wrote the book we wrote, is because we just feel like the chapters are just so confusing sometimes how they phrase it. So we put all of this into tables for you. So the follow-up is just alongside the first time you make an action plan is very similar. You just reassess their progress and everything like that. And then including building patient self-efficacy and relapse prevention. So this is self-efficacy just because it's mentioned first. So self-efficacy is determining their self-motivation and their self-confidence. So those two questions that we talked about. And one of them is their motivation is a little bit emotional. Like, I know, I shouldn't eat as much cheese as I do, but I just love it. It's like so hard to not. And then my self-confidence like is a little bit more logical. I've achieved so much and I can achieve more if I need to, like I cut out sugar and everything. And then that can build your self-efficacy, core of behavior change, which is the core of behavior change. And that's how they define it. It's the combination of your self-motivation and your self-confidence is what builds your self-efficacy. So you need to build the motivation on an emotional level, you need to build the confidence on a logical level. So relapse prevention planning is basically you want to focus on the positive, leverage their strengths, and then create a more attainable goal, invoke higher self-confidence, in order to invoke higher confidence levels so that you could build self-efficacy, and then form a prevention plan. So relapses and lapses are all part of the process. We all have broken our, our New Year's, what are they called? New Year's goals, resolutions. And so we all understand that, but we can all just get right back on that horse. There's nothing saying that it's over, it's done with, we can't do it anymore. But we should learn from each time it happened. When did it happen? What were the circumstances? And how were you feeling? Were you stressed or not? And then, is this a good time for this goal? Should we decrease the goal? Should we take out the goal? Should we focus on something else? First, you need to address that. And then is it something that we can plan to, how are we going to handle it next time? So that's the relapse prevention planning. Okay. So describe the factors that support sustained behavior. We talked about a lot of this already. So growth promoting relationships, action items are patient driven, building patient confidence, willpower, and SMART goals. Explain the role of family and other support. So they do like to, they mentioned this table. I took this out of the Foundation's book, but it's like this table of like, where can you see yourself getting support from? Are there family members that you may get support from? That can build accountability, that could actually go with you to do things, that can do things with you. Are there friends? Are there social groups? Senior centers, other groups, meetups. And then there's group coaching and shared medical appointments, and those can really help build support with patients. That's one of the main benefits of shared medical appointments. So you could support each other on your goals, and everybody that you see is kind of doing it together. And then you could support with digital technology. So I talked about the apps already, and then there's the behavior contracts. Manage disruptions to the therapeutic alliance. So basically it just says like if you are, if one of you betrays the other, lies to the other, disappoints the other, has some kind of fight with the other, then it will disrupt the therapeutic alliance. So the way to repair it is being kind, honest, open, reliable, competent, not on the test. Identify patient resources for sustainable behavior change in relation to the pillars of lifestyle medicine. Here are some resources. I don't remember any of these being on the test. And that is the end of the objectives. So a lot of content. I hope that you all also not only feel confident about what could be on the test from this chapter, but also understand health behavior change a little bit better. I try to come from that perspective as well, because I think it's really important that you realize that you're learning health behavior change, something that I feel like all physicians should learn, because it tends to be so paternalistic. Just do what I say, you're non-compliant, and that is just thrown out the window in lifestyle medicine. And I hope that you all feel a little bit more empowered from that perspective as well. So any questions? Okay. How do you feel? We have 10 minutes left on the hour, but I can either start the clinical processes and not finish it, let me just stop sharing and we can discuss. Or I could, oh, stop recording.